Differential diagnosis of leg swelling. So just for simplicity's sake, and because we only have 10 minutes, I broke it down into medical causes and anatomic causes. The most common causes that you need to rule out when you see these patients are congestive heart failure, cirrhosis, chronic or acute renal failure, arthritic causes, lipedema and lymphedema, and one I forgot to add here was medications, in particular ibuprofen, which we use a lot. Most people don't know this, but the most common side effect of ibuprofen is actually ankle swelling. Also with the calcium channel blockers. And then the anatomic causes as well. So, right heart failure. Again, I mentioned this earlier in one of my earlier talks, that one of the indications that your patient may be having some right heart failure is that during the duplex scan examination, you're going to see this pulsatile waveforms. And again, you'll see it here at the common femoral, you can see it at the junction, you can see this pulsatility here, and then those are the patients that you should be concerned about at cardiac evaluation. And again, sending them, if you have an abdominal probe, you can look at the retrohepatic IVC, and then you can see if it's dilated. If it's twice normal diameter, that's usually a pretty sensitive indicator that you're dealing with some right heart failure. And again, these are the echo images that you can see. Here's another classic example where the right ventricle is larger than the left, and then that's the D sign that a lot of our cardiology colleagues look for. So the next most common thing is cirrhosis, where you get portal hypertension. You get a lot of the intra-abdominal swelling. You can also get the esophageal varices. So clearly, in that patient that I showed you that had a caput medusa, this is the people that you have to be concerned about, that they may have some portal hypertension or inferior vena cava occlusion. And then this is what the livers look like in these patients if you've ever had the unfortunate pleasure of having seen one of these patients live in person. Another thing which is very common is lipedema. I see probably 1 to 2 patients a week in my office that have lipedema, and lipedema is different from lymphedema because typically it has this pattern here where you have this abnormal distribution of fat either in the abdominal or the hip region. If you actually turn them sideways, their gluteus maximus actually protrudes out quite a bit. This is one of the signs of the lipedema patients. The other thing that they will tell you is that this condition is inordinately difficult or resistant to weight loss measures because these fat cells are resistant. And so the tip off of this is that if you look at them, they normally have normal ankles. So the swelling will come right down to the ankles. It stops at the ankles. They don't have that buffalo hump on the foot. They don't have the stemmer sign. And then once they have this appearance, then you can pretty be confident they have lipedema. And then this is just a little chart showing you where the abnormal collections are. The one thing about lipedema that's encouraging is that unlike lymphedema, which you can't cure, lipedema patients actually respond very well to liposuction and then body contouring surgery. So there is a website called the lipedemafoundation.org. I usually refer the patients to that website, and then there's also a local plastic surgeon in my area that treats lipedema patients and talks to them about what their options are. Reflux and obstruction. So this is a graph from one of Dr. Labropoulos' paper, and in this paper, what they show is, what it was going to show is that the vast majority of patients here, their swelling is because they have reflux. There's 2% of people that have isolated obstruction, and about 16% of patients that have reflux and obstruction. So I showed this graph earlier on, just to show you where the obstruction in the pelvis could be from the internal iliacs. I'm not going to go over that again because we already discussed it earlier today. This is again the I point and the O points. And then this is just showing you the connections of the pelvis to the lower extremity. Again, high medial thigh. So this is the internal pudendal. What I failed to tell you earlier this morning is that when you see this sign here, turn the patient around. Typically what happens is these veins go into the internal medial thigh and then track posteriorly. So it comes up from the high end of the thigh, then it goes posteriorly, and then it gives you these posterolateral veins as well. Again, this is from the inferior gluteal vein, and then this is what we see normally, the great saphenous vein. And then you can see, I don't know, this doesn't project very well, but there's actually some staining here from some chronic phlebitis that's happened in this patient. Again, this is that suprapubic varicosity, indicating that there's outflow obstruction. In this patient, I told you early on, had an external iliac occlusion. So, preoperative scanning. So this is what we normally do in our offices. And then here, this is the typical sign that you see on duplex ultrasound. You see this little echogenic scar tissue here. This is a patient who's got post-phlebitic disease from a previous DVT. And then if you continue down on the long view, you see this post-phlebitic scarring in the femoral vein, and then the color duplex, which kind of tips it off further. So what I usually ask the techs to do here, and they know how to do it now because I'm going to ask them for it, I ask them to go back and make sure they look at the profunda femoris vein. I want to make sure that if we're considering this patient for any interventional procedures, that they have a good profunda femoris, that it's had axial transformation, because oftentimes the profunda is going to be the main outflow vein because the femoral vein usually scars down and contracts and usually occludes in these patients. So, and here, I don't know if it projects well, but you can see there's a diameter measurement there. That's about 0.49. It should be double that. And then in this patient here, you see some phasic flow right at this point, but if you move the cursor up a little bit more, right here, you see the speckling here, loss of phasicity. So this patient actually has an external iliac vein occlusion here. So what's my algorithm? So the first thing I do is make sure that we exclude systemic causes. Physical exam and duplex scan is very important. Typical symptoms and positive infrainguinal duplex, then that's what we do for a living, right? So that's easy, we treat that. Typical symptoms, negative superficial reflux, then a possible deep disease, that patient needs a suprainguinal scan. Physical exam and duplex suggests proximal disease, then, for example, typical symptoms, negative duplex, you need a pelvic ultrasound. And then if you've got typical symptoms, normal infrainguinal and a normal suprainguinal, make sure that patient doesn't have calf muscle pump dysfunction, very common in our morbidly obese patients. So finally, in terms of the modality, I prefer RF over laser due to the decreased pain and faster recovery time. I prefer the laser over the RF in the small saphenous vein. In the places where I've had failures, primary failures, it's been the small saphenous vein distribution with RF. So I tend to use the laser there, give them a little bit more energy. The downside of that is you get a little bit more post-op pain with phlebitic reactions, but it's minimized my failure rates in that location. And then finally, if you've had an RF laser, then the recommendation is the next thing to do is to go to the laser with cranking up the energy a little bit more. On the NTNT technologies, right now the data is best supported by Venocil, followed by Varithena and Claravane, as far as I'm concerned, has the poorest data. Even though if you look at anatomic and occlusion rates, they may have similar clinical effectiveness, but it's my third line therapy. And Varithena also has advantages of which you can treat it into the tributary disease, as you heard Kathy Gibson tell us earlier this morning. So with that, I'm going to leave you to Zoe. Thank you very much.